Oh, sorry, I will share my screen. Good morning, good afternoon, and good evening, audience from around the world. On behalf of the World Society of Pediatric Ophthalmology, this is webinar season 2, number 24 on nystagmus. And I will share my screen and bring up a couple of slides. Just bear with me for a sec. The name of this session is Infantile Nystagmus Syndrome, New Concepts in Diagnosis and Treatment. My name is Rich Hurdle, and I'm live from Akron, Ohio. And I have with me a very distinguished group of friends and panelists who I hope today we will entertain and educate you on nystagmus in infancy and childhood. Just a couple of housekeeping things. You can ask audience questions through the chat, and we will be looking at them and trying to get to as many of those as possible. The questions that we don't get to, if you feel are important and would like to get our answers, please send them in, and we will put them together in a Word document and answer them for you as we feel best, and send them out, and you can have access to them through the WSPOS website. You can access this session live, and then it's being recorded later through WebLink, Facebook, and YouTube. And type your questions on the comments session. We'll try and do as much discussion and answering as possible. The questions that were sent out regarding today, you can answer and send back to Menti, www.menti.com. And here's the passcode, 6850-7416. Again, 6850-7416. And this is how to do this. You can also use a QR code with your phone to access the site. We will be giving out an attendance or participation certificate. Just send an email to the address there, the program at WSPOS.org. And we'll be talking about our future at the end of this. So I'd like to begin the session by introducing my co-host, my friend, and an international partner in research in ocular motility and nystagmus, Dr. Lionel Covell from Melbourne, Australia, who is probably one of the greatest experts in ocular motility, strabismus, and eye movement disorders in all of Australia. He practices in Melbourne, and I've been fortunate to spend time with him in many countries, including his own. And it's really a pleasure and honor for me to co-chair this session with Dr. Covell. Lionel, it's all yours.
Richard, I think I'm sharing the screen, am I? Share.
There we go.
There we go. My interest in nystagmus began because Ringland Anderson is from Melbourne, Australia, and his textbook that he wrote 60 years ago is still a great pleasure and inspiration to read.
Lionel, you may want to hit the screen enlarge to get the whole thing down on. There we go. Sorry.
Is that better now? And Rich, you are the international leader in nystagmus treatment, teaching, and research for 35 years. As we know, you're now at Akron, Ohio. You get my award for the most generous teacher in nystagmus. You get everyone's award. And your textbook is fantastic reading, and it's a great price. Helen, we're going to hear from you today. Helen is a research orthoptist and PhD candidate in Leicester. Leicester is probably the centre in the UK for nystagmus research and treatment. And Helen, as well as being recently married, is also very highly awarded in many areas. We're going to hear from Mervyn. Mervyn has published very widely on the medical aspects of nystagmus. And Mervyn, I'm looking forward very much to hearing your talks today. Dr. Shetty is one of the busiest strabismus doctors in India. He runs pediatric ophthalmology at Aravind in Madurai, which is possibly the largest ophthalmology network in India, and I was told is busier than the whole NHS in the UK. We're going to hear from Dongsheng. Dongsheng is now in China. He worked with Rich Hurtle for 15 years and is a co-author on many of his papers. And I'm looking forward to hearing your talks. And we can see in the photo there, you, Rich, and Larry Abel in that bottom photo. And Larry. Larry makes me look good. Larry has been doing eye movement recordings in Melbourne for 15 or 20 years and has single-handedly enabled ophthalmologists in Australia to practice nystagmus clinically and surgically at a level that tries to approach that of yours, Rich. And Larry really is the nystagmus enabler in Australia. And Larry, you are our first speaker today. Would you share your screen and begin? I will stop sharing.
I will start. Let us find the topic. Well, thank you for inviting me to speak tonight. It is tonight here, and it's winter, so those of you who are in a warm place, consider us. What I'd like to do is sort of a commercial for why eye movement recordings can be valuable clinically in the management of infantile nystagmus. And I realize to my panelists here, I'm preaching to the choir, but the fact that I'm the only person in Australia doing this suggests that maybe it's not been widely adopted. And there we go. So this table of nystagmus characteristics is probably familiar to anyone who's ever opened a copy of Lee and Z or seen it from somebody else who's got a copy of Lee and Z. And with these, you can often make the diagnosis, the age of onset, the binocularity, the uniplanar nature, the presence of a null, the general absence of oscillopsia, a reversal upon occlusion. So if you've got all these, why do you need an eye tracker? And what I'd like to suggest is that there are times when the eye tracker can provide information beyond what you can see with your own eyes. And so one reason for this is that you can see a face turn and from that infer a null position, but you really don't know what's happening at the null. The general assumption is that this improves visual acuity. Our UK colleague Matt Dunn has argued it doesn't really do this very much. And in the discussion, I'd be interested to hear if people often test acuity at the null. But this was a patient with classic infantile nystagmus waveforms. And in these recordings, up is to the right, down is to the left. And mostly let's focus on horizontal eye movements. And we see here all infantile nystagmus waveforms. And as she looks to the right, the waveform improves potentially for vision. You see these flattenings where the eye is nearly stationary for longer, foveation. And it's still jerk left, even out to 20 degrees. So does it ever reverse? Well, we turned her head and then had her look further in right gaze. And here we are in primary, 20 and 25 degrees. It's now right beating. And it's a really horrible waveform for vision. no more little flat bits. Here, where fixation is just a brief turnaround. So her null lay around 23 degrees and abruptly went really bad. So recording here allowed us to precisely capture the nature of her segments at her null and on either side of that null. And this, I suggest, would be useful for the ophthalmologist planning surgical management. And the other place you often have a null, possibly by itself or with a gaze null, is at near. And one of the problems is what's actually happening at near. You might say, oh, the nystagmus looks less, but what does that actually mean? And these are two recordings that I've just pulled from my files where the nystagmus would look less at near in both cases. So here we see the left eye going right, the right eye going left, and the nystagmus virtually stops. So we go from having a good waveform in primary position at a distance of, I believe, 75 centimeters to, which is not terribly far, but it's the seating position for the eye tracker, to virtually no nystagmus. That is a really good thing. It might suggest artificial divergence surgery or base out prisms with a -1 add. Here, another really good waveform in primary position. At near, the nystagmus slows way down. It gets somewhat, maybe a little larger, but the foveation is gone. So visually, this apparent null at near probably makes things worse. And it's the recording that allows you to see that. And sometimes you don't have a good history. And what if there's not a clear null, or what if there is, but other things in the presentation are ambiguous? And so recording may help you decide, is this infantile nystagmus? And if there's a change with occlusion, where the nystagmus beats towards the viewing eye, it could be INS with a latent shift, or it could be fusion maldevelopment nystagmus syndrome, related but different entities. And the recording can tell you. And the waveforms of infantile nystagmus are unique to the condition if in the horizontal plane. They're pathognomonic. So you can use them to tell INS from FMNS or from acquired nystagmus. And this is a nice example. This was about 5 years ago. A 4-year-old girl was referred to us from the Eye and Ear Pediatric Clinic. Someone at her preschool saw her eyes wiggling. She and her mom had recently come to Melbourne as refugees from Somalia. Mom spoke very little English. The child spoke quite well for her age. No ocular history, minimal medical history. Apparently, the wiggling was only observed recently, but then she only started preschool recently. And it wouldn't be the first person where nobody actually noticed the nystagmus for years. So, quiet in primary gaze. Lateral gaze, there was a nystagmus beating in the direction of gaze. This could be a null in primary position, or it could be gaze-evoked nystagmus. Clinically, it could be hard to tell. And we recorded her. We'd been lent a video eye tracker from Toby, and so the recordings look a bit different to the iLink recordings, but here she is looking to the right, and you see a brisk right beating nystagmus. Worryingly, when she comes back to primary position, there's a rebound nystagmus to the left, which then decays. And at all times, there is a downbeat component. In left gaze, nystagmus beats to the left. You can see the decreasing velocity exponential waveform and the downbeat and the rebound. None of this looks like infantile nystagmus. And in up gaze and down gaze, the downbeat persisted even when her horizontal nystagmus essentially died out in primary position. And she had oscillopsia. And verbally and by moving her hands, she was a very bright little girl, she could match her hand movements and description to the movements of her eyes. So this is all very worryingly. She had a negative MRI, but we never got feedback about what her final diagnosis was, but I was concerned about some of the cerebellar atrophies. So what was an ambiguous presentation clinically was clearly demonstrated not to be infantile nystagmus with recording. Then there's congenital periodic alternating nystagmus. You see a patient whose face sometimes goes to the left, sometimes goes to the right. What do they have? Acquired PAN is like an egg timer. Every 90 seconds, it reverses. CPAN can be really irregular, with one direction going maybe for 10 minutes. It's very hard to stare at a patient for 10 minutes. Socially, this is awkward. The eye tracker can do it. And so what does it look like? Here's somebody with a right beating nystagmus that fairly abruptly goes left beating, and then they flip back to the right, and then they go into a persistent left beating nystagmus. Just making sure that all these little messages, no, they are not relevant to the talk. And then a few minutes later, the left beating nystagmus transitions back to right beating. And this can avoid surgical correction, say 3 out of every 5 minutes. So you can identify congenital periodic alternating very nicely with an eye tracker, whereas doing it in the consulting rooms by looking at the patient can be really socially awkward. And telling fusion maldevelopment from INS with a latent shift. Here's the manifest nystagmus of someone fixing with their left eye. You can see the tiny left beating nystagmus. Then you cover their left eye, you get a brisk right beating nystagmus. Cover their right eye, a brisk left beating nystagmus. The linear to decreasing velocity waveforms are characteristic of fusion maldevelopment. In contrast, an INS recording with a latent shift, here right eye fixating, and you have a dual jerk. There's a little pendular component riding on a jerk waveform, and it reverses and becomes somewhat different, but still dual jerk with left eye fixation. Totally different waveform, and only recording lets you know. So why don't you all have eye trackers? It's not the cost. For 40,000 Canadian dollars, you can have an iLink 1000 plus. Now, very few eye trackers are marketed as clinical instruments. Most of them are marketed for marketing. That's the big, market for eye trackers. And as Rich mentioned while we were waiting to get started, that cardiologists now read ECGs routinely. Ophthalmologists don't routinely read eye movement recordings. Neuro-ophthalmologists do somewhat, but they don't generally look after nystagmus patients. And setting up eye trackers mainly requires a degree of computer programming, which isn't often found in eye care settings. And the analysis, again, is unfamiliar looking at these squiggles. So probably all of these points except cost play a role. So what can be done? Maybe simpler hardware, less programming, more plug and play. And maybe don't do research quality recordings if you don't need that degree of quantification. And maybe use AI. Last year, 7,000 AI and ECG papers were published, none on the nystagmus analysis. So I hope I've made a pitch for why you should all be using eye tracking, and some of my friends here and I thank you for your attention. And I will now cease sharing.
Thanks, Larry. That was excellent. It's I like to hear talks about eye movement recording, but unfortunately, I think that creates nystagmus in the audience, which means to nod, right?
Yes.
But
yes.
someday, I hope that in my lifetime, that eye movement recordings will be part of at least ocular motility services at some level, and will help clinicians in the same way that many of our other electrodiagnostics do. And it may require those of us who use it on a regular basis to work with the manufacturers so that we can come up with algorithms that allow the clinician to easily be able to do a recording and get the data they need to help the patient. So hopefully we can help that. The people around the world who use it can help us as well. I'd next like to introduce, I'm proud and honored and happy to introduce Helen into our community. I'm so excited that we have some young, talented, energetic, intellectual people who chose to help study this group of patients, even bringing their skill set to us. So I hope you will all welcome her as I have into our network of nystagmus gurus and scientists and clinicians. So Helen, we're really looking forward to hearing from you.
Thank you very much. Thank you for the lovely introduction as well. It's fantastic to be here today, so thank you for that. Let me just pop up the slides. Hopefully that's all visible. So yeah, I'd just like to say a huge thank you for the opportunity to be here today and to present and engage in some very interesting discussions, I'm sure. So my talk today will be on how genetic evaluation can help with the diagnosis and classification of infantile nystagmus syndrome. I work very closely with Dr. Mervyn Thomas, who leads many of the genetic studies here in Leicester, and he will actually be giving a talk next today on ophthalmic imaging. So these are just my financial disclosures. So here's a very simple overview of some of the key historic milestones that we've reached so far with genetic testing. Back in 1953, the discovery of the DNA double helix structure was made, and approximately 25 years later, Sanger sequencing, which describes testing for single genes, was introduced. The first published draft of the human genome occurred in 2001, and in 2009, next generation sequencing studies for humans began. And then it was only in 2012 that whole genome sequencing was introduced through the 100,000 Genomes Project. So infantile nystagmus, as we know, is a rare disorder, and it often arises due to mutations of genes involved in the development of the retina, brain, and the oculomotor system. And it can be considered as a genetically heterogeneous disorder. And our focus today in this presentation will be on some of the common forms of infantile nystagmus syndrome, which is albinism, FRMD7 mutations, and SLC38A mutations. Today, I won't be talking about inherited retinal dystrophies, as these have already been excellently covered in previous webinars. So here I'm just going to go through a more specific overview of the genetic history related to infantile nystagmus syndrome. So pre-2000, the genetic basis for albinism, PAX6, and photoreceptor dystrophies were identified. And jumping to 2006, the team in Leicester discovered the FRMD7 gene, which is one of the major causes of infantile nystagmus. And this formed a stimulus for Leicester's genetic and clinical studies, and it was followed by a number of interesting papers, including characterizing FRMD7 mutations and also periodic alternating nystagmus. And this all led to the first NHS genetic test for infantile nystagmus in 2011, which was developed as a collaboration between the team in Leicester and in Nottingham. And in 2015, nystagmus was included as a rare disease in the 100,000 Genomes Project. Then in 2017, the team in Leicester developed a gene panel for nystagmus, demonstrating proof of concept for the clinical utility of targeted next-generation sequencing. I just want to highlight the importance when in clinic of taking a thorough family history and pedigree, which I'm sure we all already do, but this can give insight into potential inheritance patterns of the disorder in question, which may then refine the potential diagnoses. So consideration must be taken regarding penetrance of the disorder when considering affected family members. For example, in ocular albinism, which is an X-linked disorder, female carriers are generally unaffected, only sometimes demonstrating subclinical characteristics such as mud-splattered fundus. But conversely, let me just show you this video here. So this proband has an FRMD7 mutation, And as we can see, this child is demonstrating horizontal conjugate nystagmus. Now, if we now have a look at the child's mother, we can observe that she's affected with jerk nystagmus in all positions of gaze. And approximately 50% of females with a heterozygous FRMD7 variant are affected with nystagmus. So it just demonstrates that there can be variable penetrance with X-linked disorders. So this here is an example of a diagnostic workflow for nystagmus. Often children need to undergo a battery of tests, sometimes under anesthesia or sedation, which is not only distressing for the patient, but also for the families. Moreover, the diagnostic yield for some of these investigations is poor in children. So therefore, we ask if there's a role for next-generation sequencing as a frontline diagnostic tool, potentially obviating the need for some of these extensive investigations by just taking a simple saliva sample. So in the new proposed pathway, as you can see, we're able to utilize next-generation sequencing as this frontline diagnostic test, often starting with just saliva or blood sample. However, it's really important here to remember that this is not to replace the good clinical workup, but to do alongside. Identifying the cause of infantile nystagmus is challenging due to the diverse range of genetic disorders that are associated, in addition to the significant phenotypic overlap. So in albinism, there exists a spectrum of phenotypical characteristics. For example, as shown here, the varying severity of iris transillumination defect, and also there's varying degrees of arrested retinal development from grade 1 to grade 4 foveal hyperplasia. There is phenotypic overlap, therefore, with other disorders such as FRMD7 mutations. There's also significant phenotypical similarities between SLC38A mutations, ocular albinism, and PAX6, where they all are associated with infantile nystagmus and foveal hyperplasia. Ocular albinism and SLC38A mutations also demonstrate chiasmal misrouting on VEP testing. And it was previously thought that SLC38A mutations were strongly associated with anterior segment dysgenesis. However, our recent paper identified that it's likely a minor association. In our paper, we also described the largest cohort of SLC38A mutations to date, where 90% were initially misdiagnosed as PAX6 or ocular albinism, and were only identified as SLC38A mutations following genetic testing, therefore highlighting a really important need for this genetic testing. I wanted here to give one example where a molecular diagnosis established from the nystagmus gene panel altered the management plan for a family. So in this figure, it's a pedigree of a family that presented to us with nystagmus, headaches, and ataxia. And the children in the second generation were of school age, but unfortunately, they frequently missed school because of the severity of their symptoms, particularly the headaches. So it's also worth noting here as well and highlighting that the mum was also an egg donor. And from the egg donation, she conceived dizygotic twins, both with nystagmus and ataxia. And then from the eye movement traces here, you can notice that the nystagmus is multiplanar, although it is predominantly a downbeat nystagmus in here. So our nystagmus gene panel identified a splice mutation in channel A, which is a calcium channel gene. And this is known to be responsive to acetazolamide. So using this information, we were able to start the family on acetazolamide. And remarkably, the family's symptoms improved. So much so that the children's school attendance actually also improved as well. So this was a fantastic outcome and just highlights the importance of genetic testing to help alter the management. So I just wanted to give a brief overview of some of the pros and cons related to genetic testing. So it can enable for more precise and earlier diagnosis. It can be used potentially as a frontline diagnostic tool. It can obviate the need for extensive clinical testing. However, obviously the clinical testing will still need to be carried out also. Genetic counselling can also be enabled from this, which can inform the patients and the families of prognosis and future family planning. It can work towards precision medicine. It can be useful in children where clinical examination might be really challenging. and it can enable for the future enrollment into gene therapy trials. However, it is still quite an expensive test, although this is reducing as we learn more and as the technology advances. There is also limited available in some areas of the world, and it can take a long time to receive results, sometimes between 3 to 6 months. There's also a difficulty with interpretation of the results, and there's a lot of challenges associated with consent. And approximately 30% of cases are still unresolved through genetic testing. So just with regards to the future of genetic testing, it appears that whole genome sequencing will become more readily available, enabling the growth of precision medicine. We'll likely see the availability of virtual panels and gene therapies arise while seeing further reduction in costs of this genetic testing. So in conclusion, genetic testing is rapidly evolving as technology advances and our ability to handle big data improves. Genetic testing has the potential to be used as this frontline diagnostic tool, which can influence management plans and enable genetic counseling. And some of the key challenges associated with genetic testing are the ability to interpret these large generated data sets and also the consideration over consent. And in the future, we're likely to see gene therapies for diseases and increased availability of genetic testing. So I'd just like to extend a huge thank you to the rest of the team in Leicester working on some of these very exciting projects. I'd also like to hugely thank the organisers for these excellent webinars, again, for inviting me today. And thank you ever so much for you all for listening.
Well, that was really good. Thank you very much. You've brought me into the 2020s now. Thank you, Helen. Now,
thank you very much.
Rich, in America, there's at least one commercially available panel for patients with nystagmus. Do you use it for every patient?
I do a lot of genetic testing now. I have in the last year. I think that I've recently put this data together, 176 patients I've done genetic testing on. And I use, right now, the panels I'm using are specifically organized by a company called GeneDx, capital GENEDX. And they use saliva samples. And I'll do this for either retinal and or optic nerve and or nystagmus disease. And I've found that about right now that I'm getting about a 35% positivity across the board, except in albinism, where working with the group in the UK, we're able to consolidate a lot of genotype phenotype data now. So I'm getting a lot of information about the genetics of albinism and a bunch of FRMD7s. I've diagnosed a lot of retinal dystrophies and degenerations as well. So yes, we're preparing at Akron to do gene therapy. We're setting up in the Vision Center a process to initiate gene therapy, working with the University of Iowa and Rochester, doing it so that it will actually be prescriptive, so that finding the patient with the gene defect and then being able to acquire the gene therapy product and put it in the part of the eye that needs it, either with the help of vitreoretinal surgeons, intravitreal injection. We see medicine going in this direction in the next 5 to 10 years. And we see this as a routine process for this population of patients, because I believe that in infancy, at least early infancy, many of the patients with childhood genetic diseases will present with infantile oscillations. And that's something that we always discuss and want to bring up, is the diagnosis and the names and the way this is brought up. And the more and more I understand about this, the more I think of in terms of infantile nystagmus syndrome as a diagnosis similar to amblyopia, where amblyopia is the result of the right problem at the right deficit at the right time. So anisometropia, strabismus, ametropia, deprivation can all cause changes to the brain that result in very similar neuropathology. And so for infantile nystagmus, the motor system looks the same when we do the recordings. If they have albinism, if they have achromatopsia, if they have aniridia, there's a little bit of controversy on it, but these diseases that occur in early infancy all disrupt the developing system at a very specific and crucial time that results in the motor oscillation. So the motor oscillation is a sign of a developmental disturbance, which is often associated with the genetic disease. And I think that's the backwards way to look at it and say, so we have an opportunity in this population of patients to find out what else is going on. And in my clinical lifetime, the diagnosis of idiopathic infantile nystagmus has decreased from about 40 to 60% to about 5 to 15%. So that about 85% of patients with an onset with the motor oscillation using eye movement recordings, the motor oscillation of INS can now have know why there was a developmental disturbance at that crucial period in time, whether it's brain or retina. Now, there are some that we may believe that are pure on the motor side, like FRMD7 may be a pure motor disturbance. It may be a motor disturbance that disrupts the developmental communication between the afferent and efferent system at the crucial time. I think that's what they all have in common, is this network problem. This is a network disturbance. This is a disturbance in the infant's ability to see and the infant's ability to move the eyes, not primarily in their pathways, but in their communication. Because I can mess the optic nerve or retina up in a 6-month-old and I won't get nystagmus. And I can do the same defect. I can cut the optic nerve or give them a cataract the same way. So it's this developing communication between the two systems at this crucial time that's disturbed that results in this motor oscillation that persists throughout life. And I think if I can sum up this disease in 2 sentences, that's how I sum it up. And now with the advent of genetics and the work that's being done in the diagnosis, we can now whittle down this and we can find this developmental disturbance. Here's the cool thing. How about if we treat that at the time, as Helen got to, just like we treat cataracts for deprivation amblyopia, and they never get the nystagmus, so they don't get the amblyopia. We could do the same thing. If we could reverse the developmental disturbance, the communication disorder in the first few months of life, then even if we do it for a month, they won't get the nystagmus later. They can have the same problem, but if we can interfere with the oscillation's development in the first few months, then they won't have the problems of the nystagmus. Because in my experience, when they get older, what's bothering them more is not the original developmental disturbance, it's the nystagmus. That's what's left over and causes all the problems, and that's what we wind up treating. So,
Rich, the Gene DX nystagmus panel, how many different diseases?
Oh, God. I forget the exact number, but it's in the hundreds.
Wow.
Yeah.
And just ballpark, is that cost $1,000 US?
It's quite expensive. Yeah, it's very expensive. If the patient's insurance doesn't pay for it, then most of the patients won't do it. Although I have a fund that we help some of the patients with, and there's a service. That's why, and I'm sure Ed will remind me talking about it. Dr. Ed Stone in Iowa is helping develop a gene testing service that he hopes to be fully philanthropic for us in the United States at this point. Right?
Wow.
It's supported totally philanthropically. I'm sorry, go ahead, Helen.
Sorry. I think with the nystagmus gene panel here, I think, and Mervyn, correct me if this is wrong as well, but I think there's about 460, 470 that we're testing for on this, which is amazing, really. And Rich, I also massively agree with what you were saying as well, and in the sense that we're hopefully going towards this predictive and proactive approach rather than reactive with the nystagmus. It will be amazing if we can one day do this, and it's certainly the way we're going. So it's a really exciting time in genetics, and it's a rapidly evolving time. So it's with the technology increasing and our ability to handle big data, it's no longer being able to find the mutation, but it's just that challenge with interpreting it. But soon, hopefully, our knowledge and ability to do that will keep on increasing.
Yeah, and we need to partner with experts like you. One of the things I was going to ask is that what I've found to be a problem is my ignorance in this. And I don't think I have the brain power anymore to start over. So I need help. And getting a genetics counselor involved, getting people who are involved directly in genetics and importing them into our field. I think that in order for us to keep up with that or to be up with that, we need partnership with experts on the genetic side. Don't you agree?
Absolutely, yeah. It's a really important relationship to have that between clinicians, patients, and the genetic counsellors, because ultimately they're the ones that can really deliver that information and work with the families throughout the whole journey. So it's really important to highlight as well, prior to getting that genetic testing, that the parents and the families are really informed with what this actually means and the process of it all, and what they might find out from it, but also what might be missed from it as well. So to get that information right from the start, that genetic testing, it won't necessarily bring up the actual mutation. There might be things that are missed, whether it's a deep intronic variant or perhaps there's deletions, duplications that can't be picked up by this specific test. So that information right from the beginning, working with genetic counsellors, and I know it's a challenge sometimes to be able to have the availability of genetic counsellors there, but when we can all work together to go through this process, it's fantastic, really.
Yeah, that's great. This is a super sub. Just a quick minute. I know we're a little bit behind. I know, Mervyn, you incorporate genetics into your practices. Do Dr. Yang and Dr. Shetty, do you at all incorporate genetic testing into your practice with your patients? Unmute, Don Shang. Don Shang, unmute.
Yeah, we are not including genetic testing, Dr. Hurtle.
Okay.
Just doing clinical examination, and we're not including genetic testing.
Okay.
So we do that too. Yes, we. So in the last few years, we probably so far have more than 300 patients that had the genetic test. It helps a lot for the diagnosis.
Great. Well, I think that this is also an opportunity for us internationally. Wouldn't you agree, Mervyn, to collaborate? And Helen, because they're rare, right? And so the more that we can collect the phenotype, genotype data, the better we're going to be at this, right? And so I think one of the healthy things to do over the next decade is to try and see if we can find a way to continue to merge our data, you know?
Exactly, and I think as we've already been collaborating, as you know, Rich, that is to expand that further and provide opportunities and exchange knowledge as well, because as Helen said, the difficulty nowadays is not generation of data, but rather interpretation, and that comes specifically with the expertise within the field. So yeah, I completely agree.
Yeah, that's great. Well, great discussion. We'll continue this a little bit more after the talk, but we will now ask Mervyn to speak, and I'm looking forward to this as well. Thanks, Mervyn.
Thank you. Okay, so can you see my screen?
Yes.
Great, thank you. So hello, everyone that's tuning in from around the world. Thank you, WSPOS, for organizing the session and also inviting the team from Leicester to share our experience on nystagmus. It is an absolute privilege to be part of this panel today. So over the next few minutes, I'll discuss about imaging in infantile nystagmus syndrome. These are my financial disclosures. So imaging in adults is quite easy, as you know. You give a fixation target and within a few seconds you have an image. But in children, this is tough and it requires much more patience and a lot of skill. In table-mounted devices, you have to physically take the child to the actual machine. And this is an example of a picture on the right showing the flying baby position, which some of you may have come across or seen in the literature otherwise. And moreover, kids are drop phobic. So, you know, are there non-Mydriatic solutions that would be quite useful is also a question to be asked. So if any of you play video games, you may see this at the start of the game. You choose your level of difficulty, easy, medium, hard. Easy is the one that you do that if you think about it in terms of an AMD patient who might be able to just scan themselves nowadays. And whereas on hard is a child that is non-cooperative. But imagine if you've got a child who's got nystagmus as well, where the target or the actual eye is oscillating, which makes it even more difficult to capture the area of interest. So that's ultra hard, I guess. And over the years, imaging has evolved, especially pediatric imaging pediatric ophthalmology imaging has evolved. In the 1980s, you had sort of standard fundus photography. 1990s, late 1990s, by then you had sort of time domain OCT. This was still quite slow, so it wasn't really used in nystagmus. And then in the late 90s, you have ultra wide field imaging, sort of RETCAM. And it was sort of only 2012 when handheld OCT came into play. So during this period, also the resolution of images improved, the speed of acquisition also improved. And one of the key questions that was asked quite early on, this was back in 2013 when we published this, is how reliable is OCT imaging in nystagmus? And you've seen some waveforms already from Larry earlier on. And this is just showing us a few scans which are superimposed on a nystagmus waveform. And what we're trying to show here is that majority of your scan, because of how fast these machines are at acquiring scans, they tend to be during the foveation period and the slow phase. So there's very minimal distortion. Only minority of scans, the ones in red there, actually coincide with the quick phase. So you can actually take longitudinal measurements that is reliable over time as well. And for a qualitative purpose, for a quick grading of the scan, you can do that quite reliably, even in the presence of nystagmus. The great thing about handheld devices is that you can actually bring the device to the child. This is just a photo showing one of our orthoptists scanning a child in clinic. And this is one of our doctors scanning a child in a ward setting. And I just wanted to share a video now of doing a handheld OCT. So this is Dr. Arti Patel. She's one of our doctors that I work closely with at Leicester. And she works quite a lot in ROP specifically, but she's just demonstrating here using a handheld device. This is the Leica NV-Zoo. And it's just the distance of how close the probe is to the eye here. You can appreciate you can do non-mydriatic imaging, so they don't need any dilating drops. But the key thing here, again, is there is skill involved. You have to maintain the fixation of the child, if possible, give them some distractions, and so on. So in Leicester, previously what we used to do is we had sort of orthoptic assessments followed by the ophthalmologist reviewing. You might decide to do further investigations, diagnose and treat. And the further investigations can range from a number of different modalities. And then over time, eye movement recordings also became more frontline. And more recently, what we've been doing is using handheld OCT quite early on. So every patient that comes through, by the time they come to see the ophthalmologist, they have already a large amount of data to make clinical decisions. And what this in turn means is that increasingly we're doing less other investigations because we're arriving to a diagnosis much earlier on. Next, I just wanted to quickly touch on foveal development because this is very closely linked to nystagmus. And we know that a number of conditions that are associated with nystagmus have abnormal foveal development. I won't go into too much detail, but overall, we can divide foveal development into a number of different stages. And depending on when the arrest happens, this in turn we can use qualitatively to grade an OCT scan. And this is where you have the four sort of grades of foveal hyperplasia, as shown in the schematic. And atypical foveal hyperplasia is where you have the disruption of the inner segment ellipsoid, which is a pathognomonic feature we see in achromatopsia. So there are a couple of papers I've put there if you want to have a read of it in more detail. And the main use of this really is in applying this grading system in practice. It not only provides insight into the degree of development of the fovea, it is diagnostic, it is applicable to most disorders associated with foveal hyperplasia, which also means that it's applicable to most conditions associated with nystagmus. And it's prognostic. What we've recently been able to show is in preverbal children where we can't reliably obtain a visual acuity, we can do a scan. And then when we brought them back into clinic a few years later, we were able to predict what their vision was from that initial scan itself. So these are just a few examples of some of the scans and the number of conditions that you might come across, including albinism, SLC38A8, PAC6, and I know Helen's already touched on some of these earlier on, and also your photoreceptor dysfunction syndromes as well. So now putting a structure to this, essentially, if you imagine you're looking at an OCT scan, the first thing you want to assess is there abnormal lamination or outer retinal disruption? If that's the case, you might be considering an inherited retinal disease, such as achromatopsia and Alström's or cone rod dystrophy. And there's a number of other conditions, but this in turn might help you decide what type of gene panel you might subsequently do testing on, or whether you want to do electrodiagnostic testing. If, on the other hand, the outer retina looks normal, you'd look at the inner retinal layers, and if it continues posterior to the foveola, then that's the hallmark of foveal hyperplasia. If not, it's normal foveal morphology, which can be seen in FRMD7 mutations or other forms of nystagmus that are not associated with abnormal retinal development. If it is foveal hyperplasia, then you might consider doing a VEP. And the VEP helps in terms of determining chiasmal misrouting, for instance, and the main differentials then become albinism and SLC38A mutations. In SLC38A mutations, the cutaneous and the ocular pigmentation is normal, whereas in albinism, you have a hypopigmented fundus, iris transillumination defects, and so on. So this is just an algorithm that we use quite a lot, which helps us determine the likely diagnosis and differentials to consider. One other aspect that we explored is using Optos, which again is quite good because you can do it in undilated kids. This is just some Optos images from a patient who had SLC38A mutations, which was obtained by Dr. Jinu Han, one of our collaborators. And what we found was that in patients who have foveal hyperplasia, they also have something known as a concentric macular ring sign, which looks like a little bit of a fingerprint. When you look closely at these images, there's just a sort of an area which goes in circles. It looks like just like a fingerprint. And when you look at the OCT, actually, this corresponds to this interdigitation, where there's this hyper-reflective and hypo-reflective bands in the outer plexiform layer. And this also, so you can quickly just get an Optos as well to see whether or not this is there to determine foveal hyperplasia. There are some studies that are looking at this in terms of vision as well, like how it correlates to the visual acuity, the size of this concentric macular ring. So finally, I just wanted to end on a clinical case where OCT had quite a useful role. So this is a 2-year-old that presented with multiplanar nystagmus, no family history. The handheld OCT is shown here. What you'll notice is that there is this disruption or some discontinuities of the inner segment ellipsoid. So from the first clinic visit already, we have a provisional diagnosis of achromatopsia. ERG and VP at this age, unfortunately, this child, it was inconclusive. The NGS panel, as Helen said earlier, it can throw up multiple variants. And in fact, in this particular child, there were a few different candidate variants. Hence, we couldn't be definitively sure what the exact diagnosis was. And then the segregation functional analysis finally confirmed that, genetic confirmation was this was indeed achromatopsia. And if you imagine you didn't have handheld OCT, you may still struggle to have a potential diagnosis. And in light of the multiplanar nystagmus and so on, some may even consider doing an MRI. And at this age, it might need to be done under sedation and anesthesia. But just to give a timeline, the diagnosis of achromatopsia, provisional diagnosis, was made at the first clinic visit, whereas ERGs, VEPs can take time. Similarly, with next generation sequencing, there's a lag time between when you send the sample off and you get the results and the actual segregation analysis. So it overall can take quite a long time to get diagnosis from some of these other modalities. So just to conclude, really, retinal imaging now is quite central to our clinical workflow. OCT is almost considered an extension of our examination. It allows early diagnosis and treatment planning, less number of investigations and tests. And from our point of view, being an academic team as well, it enables both research and clinical studies hand in hand. So I just want to acknowledge all the hard work and dedication in learning and understanding nystagmus from the team in Leicester. Thank you for listening. If there are any questions or you just want to talk about science or interested cases, please feel free to reach out to me, and that's my email address there. Thank you once again to all of you for listening.
Mervyn, that was a fantastic talk. Mervyn, your audience so far includes doctors from Nigeria, Ghana, Serbia, Portugal, Ireland, Belgium, Singapore, Australia, Mexico, Vietnam, Hong Kong, Bangladesh, Ukraine, Cambodia, Sweden, Ecuador, Malaysia, South Korea. Phew.
Wow.
all of whom are Spain, Argentina, Turkey, Latvia, America, all of whom are very grateful for you bringing us into the 2020s. a question for you. Which brands of handheld OCT machines work well? Do you know?
So the one that we use is the Biotigen, which is now the Leica InVisu system. So that works really well, and we can obtain non-mydriatic images. So especially with kids, they don't like drops, so, as you know, so we like to try and do as much as possible non-mydriatic imaging. There are some other handheld devices as well, like there's the flex arm of the Heidelberg, for instance. That also, you can use it. We've tried it, and also I think the main issue with the flex arm is it's not as easy to use. Maybe it's because we're more experienced with the Leica InVisu. That might be the reason. So that's the main one we have most experience with at the moment.
Larry, do you can you give any hints as to how people can clinically tell the difference between INS and FMNS?
Clinically, I think it's very difficult because the behavior clinically is virtually the same. You occlude one eye. I think probably the one thing you'd see most often is with both eyes viewing. On average, Rich, you may want to jump in because you've seen more patients. Probably if it's INS, the nystagmus with both eyes viewing may often be more intense than in FMNS, but with occlusion, they may look quite similar, and that's certainly not a rule. You may have a fairly brisk nystagmus with both eyes viewing, it's just somewhat intensified or reverses. So that would be the one thing that I've seen in patients, but conclusively, it's the recording that documents the difference in waveform. So, Rich, would you have or Dong Sheng?
Yeah, I think that for me, FMNS is almost always associated with the infantile strabismus syndrome, mostly ESO, not EXO. So you'll see other aspects of the infantile strabismus syndrome, including a large angled strabismus, dissociated vertical and horizontal deviations, pseudo or apparent overaction of the inferior obliques. So if I see a changing direction nystagmus with cover associated with other clinical aspects of infantile strabismus, then it's probably more likely to be FMNS than INS. Having said that, about 15% will have mixed waveforms. Interestingly, you can have INS and FMNS waveforms because apparently there's an overlap in the developmental disruption. You can only see that with eye movement recordings, and the mixed component is only visible usually on binocular recordings. Monocular recordings, the FMNS comes out the most, but I think that
Richard Abadi documented that back in the 80s.
Right.
And that they're, even though they're distinct entities, there's obviously some relationship because of the way they can coexist. And certainly if there's no strabismus, that tilts the scales towards INS.
Correct.
But
if they're orthophoric and they cut, then, although if you're doing alternate cover, then you get aphoria with it, it still could be. But if you get absolutely no strabismus, if they're orthophoric and you get a changing direction, it's probably INS with a latent component.
Yeah, probably.
Yeah.
There is just a reminder now, the Menti code number 55057576. So write that down and use it, or QR code.
There's one thing I wanted to bring up. We'll move on. I know we're a little behind, but remember, I've been really interested in hearing the prognostications based on structure. And my experience, now this is 30 years of watching these kids grow up, is that structure does not equal function in childhood. It never does. I don't care if you look at the brain. I've had kids who I saw with intrauterine strokes, and they were running around the office without a hemiparesis, and their entire left cortex is gone from birth. So I think the neurologic system has a lot of plasticity, and I have not been able to correlate structure with function. I have patients with OCA1 albinism, no pigment, total hypopigmentation, or 20/70 under binocular conditions with contacts on, taking baclofen and I published this, and have had surgery. So baclofen, contacts, and surgery, 20/70, and no foveal pit, grade 4. And then I've had some that on the same thing that are 2200. And I could show you their foveal architecture, and you couldn't predict it. So I could give you all my albinism ones. I'm a little suspicious about prognostication of visual function in an immature to a mature system. And I'm not the only one. I mean, all of pediatrics has that problem, right? Predicting childhood behavior, childhood function from a single or multiple points in time in infancy or child. What's your thoughts on that?
So one of the things that handled OCT, or OCT in general, allows is it allows you to look at the fovea in a lot of detail, right? So specifically, you can assess when the retina was arrested. So for a grade 4 foveal hyperplasia, which will resemble that of peripheral retina, you've got no cone photoreceptor specialization. So there isn't the actual structure there to achieve 20/20 vision. So there's no way.
20/20 vision, and I don't want to interrupt. 20/20 vision is not the retina; it's the brain. It's the brain.
Yes.
So the brain can take retina that looks like peripheral retina. I know this because I have patients who have no outer photo. They are grade 4 and they have 20/70 acuity. So the brain is able to take less tissue and make it function more like normal tissue in children. That's my point. My point is that we cannot, I'm always hesitant to do that. Yes, you can prognosticate that, yes, it's only going to behave like peripheral retina in a mature brain, but not in an immature brain. So sure. I encourage you to continue to watch those patients and treat them. Here's the problem that I've seen in patients from around the world. Oh, my fovea is bad. I have albinism. There's nothing that you can do. Go get a dog or a cane or both, or just bank it out. You're not going to see. You're never going to drive. You know, you're going to be worthless. And it's just not been my experience. If these patients are treated, their visual function improves regardless of their anatomy, and they don't wind up to have peripheral retinal function in their central retina. And this is, you know, I've documented this in a.
I like to say I agree with you, Rich, completely. Recently, we had a patient who has an OCA1A. It's the white hair after the treatment. Her vision get 20/40, unbelievable. Yeah, 20/40. That's after a dark exposure research project, of course. But we can discuss it later. I agree with you. The fovea is flat. There's no.
So there's two things to say is that one is the caveat here is that what you're doing by looking at the retina is you're saying that the structure of the retina is this. So the limitation is related to the retina. It's not related to any other structures. So yes, the brain might be able to adapt and so on. The other aspect to just also mention and to be cautious about is when you do these images, it's quite easy to not get the fovea because they have nystagmus. You might not be getting a central slice through the fovea. It might be that it's slightly parafoveal, and we've seen this, it's happened to us, sure. Where we're not actually acquiring the actual central foveal
sure.
pit. And this is very easy to happen. And therefore, you might interpret it as this is a grade 4 foveal hyperplasia, but in fact, it might not be the case. Okay. So that's just a word of caution to be aware of as well. But ultimately, we're not saying that this is a limitation, but we're saying, okay, the retina looks like this, which means that we expect that perhaps the vision might be this. It's not that this is the end of the line as such. Okay. The converse of that is that if someone has really good, really poor vision, and they've got a good foveal pit, you want to find out why that's the case, right? Because you want to really explore why aren't they achieving the potential vision that they should be achieving. Sure. And that's the flip side of it as well.
Yeah, no, I agree. There's a reason to use this, and we're figuring it out. We're in the process of figuring it out. All right, I don't want to keep. We can get back to this. Let's thanks to our next speaker. Dr. Shetty will be speaking next.
Can I share my screen?
Yes, go ahead.
I'm seeing Dr. Richard Hurtle's.
No, there's nobody is sharing. If you go to share screen, the green in the middle.
Yeah, it is not coming. It's showing a desktop.
There we go.
Yeah.
There you go. You got it. Thanks.
I'd like to thank, good evening, good afternoon, good morning. I'll be talking on surgical indications for nystagmus. I'd like to thank WSPOS for creating such a excellent webinar. And I'd like to thank my online mentors, Dr. Richard Hurtle, who was very instrumental in helping me in dealing with patients with nystagmus, and also Dr. Leonel Koval, who also was very much instrumental in helping me out with these patients of nystagmus. So I'll be just sharing a few important tips and tricks in deciding which patients are good candidates for nystagmus surgery. I don't have any financial interest or any financial disclosures. So what are the goals of surgery we are looking at? We are looking at to increase the fovation time in these patients and helping to broaden and deepen the null zone and basically straighten the head and the eyes. So the indications for treatment, when we look, we're not looking at visual acuity because the visual acuity is again very variable. And most of the studies looked at the time to see. So when we do the surgical corrections for these patients, so the time to see actually gets better. The gaze-dependent visual acuity gets better. And if the patients have abnormal posture, that is also another indication for treatment. And actually, when we treat these patients, we are actually improving the effective field of the best vision because we are actually treating the nystagmus not in the primary position, but improving the vision in all the 9 cases. And if they have associated oscillopsia, which also gets better after the surgical treatment. So these are all the indications for the surgical treatment. So when we see a patient with nystagmus, we have to take the proper history, the history of onset of nystagmus. That is very important because from the birth to 6 months, we classify them as infantile nystagmus syndrome. Above 6 months of age, we should be very skeptical, and we are classifying them as acquired onset of nystagmus. And we have to take if there's a family history of nystagmus, and also from the history, we should look at the head posture. And while doing the clinical evaluation in the clinic, we have to again look at the head posture. We have to look at the visual acuity in all the 9 gazes. And neuroimaging should be done in patients with acquired nystagmus. And electrophysiology in patients to rule out the sensory deficits. So when we do the evaluation, we have to do a proper orthoptic evaluation. We have to look at if the patient is having associated strabismus. Eye movement recordings, we have to differentiate between INS and other types of nystagmus, like with FMNS and nystagmus blockade syndrome. And we have to look at their fovation period. Nystagmus, expanded nystagmus acuity function test is very important. And neuroimaging in patients, periodic ordering nystagmus can be suspected in patients with INS who have a latent component and they fix in abduction. And when they have changing visual acuity in different visits. So you should be suspecting aperiodic alternating nystagmus. And in head posture, whenever we evaluate a head posture, we should always try to correct the refractive error. Most of the patients have with the rule astigmatism, and all the studies which revealed, we are done on the refractive error studies, and they found most of the patients have with the rule astigmatism. And once the refractive error is corrected, sometimes the head posture is corrected. That's better. Head posture is dynamic because it can keep on changing. So it is not a very reliable measure for evaluating a patient with nystagmus. It is very difficult to measure accurately because it can change. It depends on the patient, depends on the stress factor what the patient is undergoing. It can be very variable, and it's a compensatory response to the nystagmus. So it is not a pathology, it is the response to what the patient is having. And always rule out periodic alternating nystagmus and aperiodic alternating nystagmus. So we use the chrome, cervical range of ocular motion, to assess the nystagmus, the head posture. It's a very useful instrument, described initially by Dr. Burton Kushner in his article, and we use it to measure both for the near measurement as well as for distance measurement. It is very useful. It measures the head posture in all the three axes. It measures the in horizontal, vertical, and also the tilt. So we usually use it for measuring, and it's very accurate. So we use the golden fixation stick when we assess the head posture for near, and for distance we use the Snellen's chart. So patient is accurately reading the resolving the Snellen chart, and we look at the measure the head posture. And I found that measuring the head posture in the initial visit is very important, because as the time goes on and the patient realizes that we are going to measure his head posture, he voluntarily doesn't sometimes keep the head posture. So sometimes we might miss the degree of head posture what the patient is having. And this is a small video which shows a periodic alternating nystagmus. As you can see, patient is having a left beat nystagmus. And then there is a small null where there is, and now it changes to a right beat nystagmus. So periodic alternating nystagmus is very important because most of the times patient can present with alternating phase turn. And when we are assessing, we should rule out refractive error. Refractive error is very important. And some of these patients who keep a chin elevated or chin depression, we should always look at the binocular vision. So patient can have binocular vision, and the head posture may be due to the binocular vision and maybe not due to nystagmus. So always evaluate the binocular vision in patients who have nystagmus coexisting with strabismus. So there was an article by Dr. Brodsky in his textbook of pediatric neuro-ophthalmology. He was suggesting that all the patients who presents with vertical head posture should be looked at, the binocular vision should be looked at, and always close either eye and look at the head posture. If you close the eye, if the close one eye and the head posture is still persisting, that is because of the nystagmus. If you close one eye and the head posture disappears, then it's basically due to strabismus. Prism adapt for the head posture to know the amount of degree of phase turn, and that can be useful for your surgical management. So always use the prisms to measure the amount of phase turn and the amount of prisms which are required to measure the to neutralize the phase turn. So this is a patient who has got a left beat nystagmus with the left phase turn, and the prisms will be kept to neutralize the amount of the phase turn. So he has got a very large phase turn, and base in prism in the right eye and base out prism in the left eye has been kept to neutralize the phase turn. And then you can see the phase turn getting better. So this amount of prisms can be utilized to for your surgical planning. Visual acuity, again, assessment is very important. Binocular visual acuity should be looked into. And visual acuity, again, is very dynamically dependent. And the visual acuity should be assessed in the preferred null gaze. And always the best corrected glasses should be prescribed for this patient. And we can use the version and the Vergennes prisms. The Vergennes prisms help in to determine whether the nystagmus gets better with the convergence. So if the patient's vision gets improved and the nystagmus gets dampened with the Vergennes prisms, then we can decide on bimedian recession, which will help in improving the nystagmus and also help in improving the vision. Eye movement recordings are important, which will help in differentiating between INS, FMNS, saccadic oscillations, and in patients with acquired nystagmus. NAFEX really helps in predicting the improvement of the visual acuity post-operatively. And we can also look at the fovation time. NAFEX, along with the longest fovation duration, measures the motor component of the nystagmus, and it looks at the best waveform, and it also predicts the best visual acuity in these patients. Importance of NAFEX, it improves with convergence because the nystagmus damps with convergence, and then we can decide on the surgical management of these patients. And it is useful for non-strabismic binocular disorder patients. And it is in patients who have very sharp and eccentric NAFEX. After surgery, we can see the broadening of the NAFEX in these patients. If they have INS, if they have coexisting with strabismus, proper orthoptic evaluation has to be carried out. Strabismus correction in patients who have FMNS can correct the FMNS into a latent nystagmus when the patient is orthotropic, and it can reduce the nystagmus. So always correct and determine the fixing eye for once you correct the fixing eye, it also corrects the face turn. So also when you do a binocular assessment of these patients who have strabismus with nystagmus, so you have to know the dominant eye, and once you correct the dominant eye, the face turn gets better. Carefully evaluate the binocular function in these patients. Two purposes of eye muscle surgery, it is center preferred post and also to improve the oscillations. In acquired nystagmus, what are the indications? One is associated, if they have associated oscillopsia, and patients who have head posture. Like in patients who have downbeat nystagmus, 5 prisms based on prisms in both the eye helps in improving the oscillopsia in these patients.
Excuse me, Dr. Shetty, we have about a minute left for you.
Yeah, thank you.
Oh, you had a minute. You could wrap up.
I'll stop sharing.
That very comprehensive overview. Thank you very much. Dong Sheng, would you be kind enough now to share your screen and give us a summary of common surgical procedures? Dong Sheng, thank you.
That looks okay. Hello. Good morning. Good evening. Thank you for the invitation. It's my great pleasure to participate in this worldwide webinar. I'm going to talk about the nystagmus surgical procedure. Really? Why? So how to quit? So I didn't show my video here, probably. How to quit this? It's not that. It's open. Okay, I'm going to share my screen. So I don't know why my image is not show up. Okay. Okay, summary of common surgical procedure. So it's going to be include 3 sections. All this classification is actually arbitrary. The first part is going to be now position surgery. Second is the rectus sternotomy and the reattachment. The third one is the one that I want to show from my experience, the recession plus resection on the same muscle for the nystagmus treatment. So first operation is for face turn. As you can see, this case has a left face turn. The right side showing the eye muscle, eyeball, right eye, left eye. So what you could do is the one pair of the muscle recession, like this we show. And also some people may prefer to have the other pair have the resection. It's called Anderson-Casbon procedure also. And you can also vary the amount of the recession. Then you can take care of the different size of the face turn and the strabismus. Second one, the chin down operation. So for chin down operation, you will first choose to recess the bilateral superior rectus of 5 millimeter. And you may also want to do inferior oblique myectomy. And as Dr. Turtle preferred, he always does the bilateral rectus, sternotomy, and reattachment, as is shown here. And what else? Can we do horizontal recession for this case to change the head posture? The third one for the chin up, as I indicated here, first is the bilateral inferior rectus recession, and then you do superior oblique stenectomy. And sometimes you do bilateral rectus sternotomy and reattachment. So for the torsional head posture, this head posture, I believe it's the complicated one. So the first choice will be the horizontal transposition of vertical recti by 1/10 width. Or you can choose to do vertical transposition of horizontal recti by 1/10 width. But you have to be careful when the head posture sometimes turn to the right, tilted to the right, sometimes tilted to the left. What you can do? Now you can use the eye movement recording system to figure out how the eye position change. As you can see here, when the right eye fixates, the left eye is higher than the right eye. When the left eye is fixated, the right eye is higher. When both eye viewing, the right eye and the left eye take a turn to be higher than the other eye. So this head posture is caused by DVD actually. So you're not working on the horizontal or vertical to do the position, transposition. What you do is to treat the DVD. Also, this is the fifth operation for the multiple planar head posture. And I always choose to operate on face turn first. This could be an AK procedure like this we show. So one pair is for recession, the other pair is for the resection. And also you can have the face turn combined with chin up like this. And but sometimes, like this patient who has the V pattern XT, he got chin up for binocular single vision. In this case, you do bilateral rectus recession to correct IXT, not the vertical muscle or anything else. So also for this multiple planar head posture, you use the new technique. We have a system that can record eye and head at the same time. Then we can get a better understanding of this head posture. By look at this eye movement recording, as you can see, when the face turned to the left, the nystagmus is almost disappeared. And also when the head had the left tilt, the nystagmus also gone. Then what we did was 2 muscle recession, okay, treated the head posture very well. So number 6 is working on the vergence. It's simply recess the bilateral medial rectus by 3 millimeter. But for this surgery, this procedure, I always have some difficulty to select the patient. Do we choose the patient who already has convergence damping, or we choose the one doesn't have the convergence damping, and then to create one for the convergence damping? Not quite sure how to select. I don't do this surgery a lot. So then my question also, can we shorten the lateral rectus when we get the same results as we do recession for the middle rectus? Okay, number 7, for primary head posture, as Dr. Hurtel's research indicated that the horizontal recti tenotomy and the reattachment T and R procedure alone can help with the to improve the nystagmus. Just 4 muscle, horizontal muscle, tenotomy and reattachment. But I'd like to extend this 4 muscle T and R procedure. I like to show you what I usually do. I do the horizontal rectus recession like this. And but we had a problem. When we do the large dorsal recession, the eye muscle actually doesn't attach to the global back enough. So it's like we expected the muscle to be inserted in the new insertion like here, but it's usually end up to attached just a little bit behind of the equator. So in this case, nystagmus wouldn't reduce a lot, and also it may cause the strabismus. So then, do we need to do a resection before we do a recession on the same muscle? Yes, we did that. And then after that, now we can get a good insertion that where we want the muscle to be attached to the eyeball. So then each muscle will have an adjustable suture. So it's easy to make any adjustment if any deviation occurs. So we can vary the amount of the recession to take care of the strabismus and the size of the head posture. So does it work? So I have some video here to show you. The front one is the pre-op, the below one is the after-op. It's very powerful procedure. This one is also, it's nearly invisible. The nystagmus becomes reduced a lot. It's not only works for the nystagmus itself, but also very good for the head shaking, like this little baby has head shaking. And then after the surgery, the head shaking is gone. So after the surgery, you may worry about if the version or vergence is limited. So by look at this video, so actually the version is not limited. And also you can see here, they have very good gaze angle. And so the eye movement is not, the normal eye movement is not limited, but the nystagmus reduced significantly. However, we do have some complication. That is a post-operative deviation. It's occurring in 3% of the patients. But the same finding in all patients is always because the recti was not inserted back enough, and always happened at the lateral recti. And even after we did a resection, that's still happening from time to time. So to my experience, the head turn, chin down, chin up, no head posture, and head shaking or multiple planar head posture. They works for all kind of head posture. So what's the working mechanism? We believe that change the arm length of the force, like this one, and maybe the level principle is applied to work for reduce the nystagmus. So at the end, I like to say that the main purpose of the nystagmus surgery is to reduce nystagmus. Sorry, there is a mistypo. Not to treat anomalous head posture only. It is important to reduce nystagmus because post-op vision improvement depends on nystagmus improvements. Vision improvement in patient with nystagmus is our major goal. Dark exposure research project after operation for further vision improvement. Thank you. Thank you very much for your attention.
Thanks, Dongsheng.
Thank you.
Unfortunately, we'd love to stay here for another hour and discuss all of the talks and answer audience questions, but we're running out of time, and we're just about done with our time. I just want to wrap up very quickly and with a couple of slides while I'm thanking the audience for their excellent, this was phenomenal. It was so great to have all this participation. And hopefully this will stimulate the rest of the world to help us with our nystagmus patients. But just a couple of advertisements where we'll be doing Connect 2 this year. We did Connect 1 last year, a roaming 24-hour international conference with specialists from all over the world. We'll be doing this Saturday, September 25th. To Sunday, September 26th, and we'll be continuing to send out blasts. You can go to the WSPOS website to see this. You'll be able to register for the meeting pretty soon. If you're not a member of WSPOS, please join us, no matter where you come from, or orthoptics, optometry, ophthalmology, and you can go to the website and join. And join our Facebook page, YouTube channel, and also David Granite's listserv, which has been going on for a long time now. I think it's old enough to have grandchildren, and we're really happy that that's continuing. And I'd like to say thank you to everyone for their time and energy, and to participate, to take time out of their weekend. All of you, Lionel, thanks, Helen, Larry, Dr. Shetty, and Mervyn. Dongsheng, it's really good to see you all. And hopefully we can see each other in person very soon. If anyone in the audience really wants to get in touch with any one of us to have continued discussions, please feel free. You have our contact information through WSPOS, no problem. Thanks again, everybody. Have a great weekend.